Okay, thank you, Chair, for that kind introduction. I'm truly honored to be here at VSRNM, and I'd like to begin by expressing my gratitude to the organizing committee for inviting me to speak. Okay. Before I begin, a brief disclosure. I'm the CEO and founder of Phantomix, a company I established about 5 years ago. Our mission is to revolutionize cardiac care through AI-powered software, particularly focused on enhancing cardiac MRI and CT analysis. As we enter an era of rapid AI advancement, its impact on medicine is profound. First, AI can rival or even surpass human expertise by leveraging fast data-driven algorithms for accurate decisions and predictions. Second, AI transcends geographical boundaries, delivering consistent, high-speed medical support anywhere in the world. And third, AI can reveal hidden patterns and provide insights beyond human perception, giving us deeper understanding of complex medical data. The push for AI in cardiovascular imaging comes from real, pressing challenges. We are dealing with a rising number of imaging examinations, increasing in both volume and complexity. Think multidimensional CT and MRI. This puts immense strain on clinicians and workflows. Current techniques are often operator-dependent, introducing variability and the risk of missed findings, especially under heavy workload and fatigue. And the consequences for patients can be serious. Missed early diagnosis of delayed care. This diagram illustrates how AI is transforming every step of cardiac imaging, from selecting the right test and optimizing protocols to image reconstruction, analysis, and reporting. AI can highlight subtle findings, support risk assessment, and reduce reporting burden. Of course, it also raises important considerations such as ethics, transparency, and sustainability. But the trajectory is clear. AI is making cardiovascular imaging more precise, efficient, and patient-centered. To understand where we stand, let's consider the technology readiness levels, or TRL, of AI in cardiac imaging. On the left side, areas such as patient selection and workflow optimization are still being validated in research. As we move to the right, we see that many tools, such as image reconstruction and quantitative analysis, are already being used in real-world clinical practice. For example, deep learning CT reconstruction and automated plaque analysis have reached maturity and are now part of routine care. Now that we've set the stage with AI's overall potential, let's look more specifically at how AI is being applied in radiologic diagnosis within cardiovascular imaging. Last year, Professor Choi Byoung and colleagues at Hua Hospital, China, published groundbreaking research using AI-enabled cardiac MRI for disease screening and diagnosis. This was a milestone demonstrating not just the feasibility, but AI's potential to fundamentally change cardiac care. The team developed two distinct AI models. The first was a screening model for 11 cardiac diseases, trained using only 4-chamber and short-axis cine images. The second was a diagnostic model using cine and LGE images. Both models were trained on nearly 10,000 patients and performed well across internal and external data sets. While performance dipped slightly on external validation, accuracy remained high. Notably, the diagnostic model even outperformed cardiologists in identifying pulmonary arterial hypertension, suggesting that AI can detect features in MRI that can escape from human eyes. Turning now to CT, researchers evaluated an AI tool for coronary CTA directly in the clinic. In over 1,000 patients, the AI delivered critical outcomes, such as calcium scoring and catheterization in under 5 minutes. When compared to expert reports, agreement was substantial. The tool showed a 98% negative predictive value for ruling out significant coronary disease, making it highly reliable in triaging patients. A meta-analysis brings all of this into perspective. Across multiple CT studies, AI models consistently showed high accuracy in detecting coronary stenosis. They not only agreed substantially with expert radiologists, but also cut review time by an impressive 76%, from about 12 minutes down to 30 minutes. Equally important, AI improved diagnostic performance across all readers, particularly for identifying high-risk plaque. So the evidence is clear. Deep learning is accurate, efficient, and ready to transform how it detects stenosis in clinical practice. With that foundation, let's now focus on how AI is automating some of the most labor-intensive measurements in cardiovascular imaging. Cardiovascular imaging is very notorious for this kind of labor-intensive processing. So take coronary artery calcium scoring first. Coronary artery disease remains the leading cause of death worldwide, and early risk assessment is critical. Calcium scoring is powerful, but it has limitations: cost, lack of reimbursement, and often calcium isn't reported on routine chest CTs. Researchers developed 2 deep learning models, one for dedicated heart scan, matched expert scoring in seconds. The other could score calcium even on routine chest CTs. And beyond calcium, AI is also transforming functional measurements in cardiac MRI. In cardiac MRI, measuring biventricular function is central, but it's time-intensive. In a study of 200 patients, 3 deep learning algorithms fully automated measurements of ejection fraction and left ventricular mass, showing excellent agreement with experts. AI correctly categorized ejection fraction in about 80 to 86% of cases, and both AI and expert results predicted cardiovascular events equally well. AI is also being applied to tissue characterization. Researchers developed a neural network trained on data from over 800 patients to segment and analyze T1 and T2 maps. The results closely matched cardiologists' assessments with the scatter plots and Blundman-Altman plot, showing agreement comparable to human experts. The real strength here is workflow integration. These algorithms can be built directly into MRI scanner, providing instant, reproducible mapping results at the point of care. To make this more visual, take these polar maps. They display myocardial tissue markers in intuitive, global way. For example, dips red in T1, ECV, and LGE in amyloidosis, broader T2 elevation in myocarditis, and blue areas in Fabry disease, Fabry disease reflecting repeated buildup, or subtle T1 changes in dilated cardiomyopathies. Even regional ischemia becomes immediately apparent. AI makes these advanced maps faster and more consistent, empowering clinicians to make quicker, more confident decisions. As we explore the future of AI in cardiovascular imaging, one of the most promising areas is the assessment of atherosclerotic plaque. This is where imaging, clinical trials, and AI converge to redefine risk stratification and patient care. Let me walk you through the evidence and innovations shaping this field. The SCART-HEART trial, that is a very famous trial, demonstrated that adding coronary CT angiography to standard care for patients with stable chest pain significantly reduced the risk of coronary heart disease, death, or non-fatal myocardial infarction at 5 years. With a median 10-year follow-up, CT angiography-guided management continued to show lasting benefits, reinforcing the role of plaque imaging in long-term outcomes. In a secondary analysis of the PROMISE trial, that is another very famous trial, major adverse cardiovascular events occurred in 3% of patients. Importantly, those with a high-risk plaque had a much higher event rate, 6.4% versus 2.4%. Even after adjusting for stenosis severity and atherosclerotic cardiovascular disease risk score, high-risk plaque remained an independent predictor with an adjusted hazard ratio of 1.72. This highlights the prognostic power of a plaque feature beyond just luminal narrowing. In patients with advanced coronary disease and moderate to severe ischemia, plaque quantification provided additional prognostic value. AI-based quantitative CT, AIQ-CT, showed that total plaque volume was the strongest predictor of death or myocardial infarction. At 4 years, adding AI-derived plaque metrics improved the model discrimination, with the AUC rising from 0.608 to 0.654. While vessel count predicts near-term event, long-term outcomes are better captured by plaque burden and composition. Several companies, for example, Clearly, Elucid, and Heartflow, are all in United States, are now translating this science into practice. Their AI-powered plaque quantification tools are reimbursed under Category 3 CPT codes in the US and validated against IVUS and pathology. Adding AI-derived plaque data to baseline risk factors has consistently improved outcome prediction at 6 months, 2 years, and 4 years. In short, AI has made reliable, scalable plaque quantification feasible in real clinical practice. Despite this progress, technical challenges remain. Fixed Hounsfield unit thresholds for contrast-enhanced CT overlap with plaque subtypes and don't account for individual variation. Adaptive thresholding based on each patient's luminal attenuation offers a more personalized approach, though no method has proven definitely superior. Variability in reconstruction, scanner type, and tube voltage continues to impact reproducibility. Photon counting CT is another breakthrough. Compared with conventional detectors, photon counting detector CT reduced the total plaque volume estimates by nearly 1/3 due to lower fibrotic plaque volumes, while low attenuation plaque volumes were actually higher. Most importantly, photon counting CT improved reproducibility of high-risk plaque measurements. However, Hounsfield unit thresholds may not transfer between energy integrating detector and photon counting detector systems, emphasizing the need for scanner-specific calibration. Looking forward, the horizon is clear. Large-scale deployment of AI-assisted coronary analysis, integration of multimodal data for personalized care, and therapeutic monitoring of plaque progression. Ultimately, prospective randomized trials will be needed to validate and cement these advances. Plaque imaging powered by AI is not just about diagnosis. It's becoming a key to prognosis, therapy, and precision cardiology. Despite these exciting results, there's still a critical question: why aren't these technologies more widely adopted in everyday clinical practice? In fact, a study recently published in the New England Journal of Medicine looked at this. Although the FDA has approved over 500 AI devices, it is now more than 1,000, the real-world clinical use remains limited. By analyzing more than 11 billion CPT claims between 2018 to 2023, the researchers showed that adoption is still in its early stages. The message is clear. Regulatory approval alone is not enough. There must also be incentives, integration, and trust for AI to be used routinely in the clinical practice. So, what are the barriers? First, data quality and integration challenges. Second, lack of transparency and legal clarity. Third, concerns around privacy, fairness, and potential healthcare disparities. And finally, slow regulatory processes. To overcome these barriers, we need transparent, explainable AI and close collaboration between academia, industry, and regulators. And this brings us to a broader issue, bridging the gap between research and practice. A recent commentary paper highlighted that most prediction models published in research are never implemented in practice. This reveals a striking gap. To bridge it, the author proposed a practical checklist for AI tool development, focusing on clinical usefulness, usability, and accessibility. The goal is simple. AI should deliver real, tangible benefits to decision-making in daily clinical work. Achieving this requires close and sustainable collaboration between academia and industry, but above all, it requires rigorous validation. AI in medicine must be tested by hospitals and imaging experts using real-world data before widespread deployment. Only then can we maximize its clinical benefits. As we look to the future, we are entering a new paradigm. This is the era of autonomous AI, AI that doesn't just assist, but can think, plan, and act independently. Large language models are already reshaping cardiovascular imaging. They can generate structured reports, support clinical decisions, and even interact with patients. Studies show GPT-4 and similar models can match human experts in labeling and summarizing imaging data. The next step is multimodal large language models that integrate images and text for even more powerful analysis. The potential is huge, but so is responsibility. Careful validation remains critical. To illustrate, KHOA's 2.0 scoring in cardiac CT is complex and often manual. Researchers tested large language models like GPT-4o and Llama 3 on 200 CT reports. The results were striking. GPT-4o reached 93% accuracy, Llama 3 about 92.5%, matching expert consensus. This shows that large language models can not only enhance efficiency and consistency, but can also be deployed securely in local open source environment. We are now seeing systems that combine three breakthroughs: large language models as brain, enabling natural communication; AI agents as the hands and feet, planning and executing tasks; retrieval augmented generation as the memory, connecting AI to up-to-date information. Together, they create AI that can understand context, access real-time knowledge, and take meaningful action with minimal oversight. But it's important to remember that this isn't about humans versus AI. It's about individual intelligence versus collective intelligence. AI's strength lies in tapping into vast collective knowledge, delivering accuracy, consistency, and speed far beyond one person's ability. The challenge is to combine this collective power with the human judgment for the best patient outcome. As AI transforms medicine, physicians must also evolve. We are not just users of technology. We are leaders and stewards. Our roles expand to visionary leaders, identifying real clinical needs and guiding AI development, data stewards, ensuring medical data sets are accurate and representative, validators, rigorously testing AI tools before adoption, change agents and educators helping colleagues and patients trust AI and use AI responsibly. Ladies and gentlemen, thank you for your attention. We stand at a remarkable moment where AI is not just a tool, but a partner in reshaping cardiovascular imaging. Together, through careful validation and collaboration, we can turn this promise into real-world impact for our patients. Thank you again.